By 36 weeks, Indian families usually have a hospital bag packed and waiting by the door. But when a sudden cramp hits in the middle of the night, preparation turns to panic, sending parents rushing into unpredictable Bangalore or Mumbai traffic. Often, the trigger for this late pregnancy pain has nothing to do with the baby. Traditional heavy, spicy Indian meals or rich lentils can cause severe digestive bloating and acidity that mimic the onset of labor. Mistaking digestive distress for a real contraction results in a highly stressful car ride and eventual rejection at the hospital triage ward. Families must balance the psychological urge to rush to the hospital against the clinical requirement to track symptoms at home. Dr. Prashanth emphasizes that clinical observation accurately distinguishes a uterine rehearsal from the actual birth performance. Those rehearsal cramps are called Braxton Hicks contractions. They are mild, irregular practice squeezes of the uterine muscles that happen frequently in late pregnancy. Looking at this anatomical model, you can see exactly how these practice squeezes operate. They are felt strictly as a tight, uncomfortable band pulling horizontally across the front of the abdomen or right at the groin area. If you touch the belly, it might feel rock hard to the touch for a few seconds, but that sensation will fade away completely. Most importantly, Braxton Hicks contractions lack a predictable rhythm. They do not establish a pattern, and they do not get progressively closer together. Because there is no steady, driving rhythm behind these irregular cramps, the cervix is not actively stretching or opening. When the pain lacks a strict pattern, families can safely stand down the alert and pause the panic. When that sudden belly tightening occurs, your first physical test requires no equipment. Simply change your physical position. If you were walking, sit down. If you were sitting, lie down on your left side. This microscopic view illustrates a hidden danger: dehydration. A dehydrated muscle is highly irritable, violently twitching until proper hydration washes over the fibers. To counter this, the mother must immediately drink exactly 2 full glasses of water, or a warm glass of Jira water, along with a small, light snack. Now watch the clock. If this is false labor, changing positions and hydrating will make the contractions vanish completely within 30 minutes. This 30-minute window serves as a diagnostic tool, confirming the body was only practicing and allowing the family to return to sleep with confidence. However, if you rest, hydrate, and change positions and the pain still does not stop, you must shift your focus to active tracking. True labor announces itself with a very specific, undeniable rhythm. It commands your full attention and forces you to stop whatever you are doing. This timeline shows how you measure that undeniable rhythm. Track the cramps for at least 1 full hour to see if a scattered pattern organizes into a strict sequence. Throughout this 60-minute window, real contractions obey strict metrics, getting progressively closer, stronger, and longer. And during this full hour of discomfort at home guarantees that when you do leave for the hospital, it is for a necessary, confident admission. During your tracking hour, carefully observe exactly where the pain originates in your body. Location is everything. This 3D pelvic model tracks the distinct path of a real contraction. It almost always initiates as a deep, heavy ache strictly in the lower back. True labor pain actively wraps around your sides, pushing forward into the front pelvis and radiating down into the upper thighs. A true labor contraction lasts for 30 to 45 seconds before the uterine muscle fully relaxes. That sustained, intense pressure pushes the baby downward against the pelvic floor. This specific wrapping sensation and sustained duration confirms that the uterus has shifted from rehearsal to actual performance. As those rhythmic wrapping contractions continue, they perform the invisible, essential work of cervical effacement. Cervical effacement is the gradual thinning and softening of the cervix to prepare for delivery. This cross-section reveals the mechanics of effacement. The cervix, the tight lower opening of the uterus, slowly thins out and stretches horizontally. Because the tissue is actively stretching, tiny blood vessels on the surface break under the tension. This microscopic breakage creates what is known as the show, a thick, blood-tinged, sticky discharge that appears pinkish or brownish. This physical discharge provides the definitive proof that the birth canal is actively opening. To the anxious family members, while the mother manages her pain, you have a critical job. You must continuously monitor the baby during this tracking hour. This diagnostic matrix highlights a mandatory safety rule. The baby must continue moving normally between true labor contractions. The relaxation period between cramps is when the uterine muscles loosen, allowing the baby to recover. Feeling those normal kicks and rolls is the sign of a safe, healthy progression. Actively tracking fetal movement transforms the family's nervous energy into vital clinical observation. This checklist outlines when to grab your bags. First, the undeniable rhythm must reach a point where contractions come steadily every 5 to 7 minutes. Second, each contraction must last intensely for almost a full minute. Physically, the mother will find it impossible to walk or talk through the pain. 2 red flags immediately void the 1-hour tracking rule. Consult your doctor immediately if there is a sudden gush of watery fluid from the vagina. The second red flag is pain that morphs into a constant, tearing agony with zero relaxation between cramps. This indicates an obstetric emergency. By combining the undeniable rhythm, the back-to-front pain rap, and visual evidence, you can confidently navigate midnight traffic, knowing you are arriving at the hospital exactly when you are supposed to be there.